like to introduce Dr. Prasana Nair. Dr. Prasana completed her Masters of Internal Medicine from University of Malaya in 2021. She subsequently joined UMNC as a clinical specialist. She's currently doing her neurology subspecialty training in UMNC. Recently, she was awarded Rising Star Award by Malaysia Stroke Council at Malaysia Stroke Conference. And with that, we are delighted to introduce and let Dr. Prasana talk.
Thank you, Prof. Sharon, for the kind introduction. So, I'll share. So let me share my screen first, yeah. Good morning, everyone. Good morning, all the virtual audience that we have today. So my name is Prasana. I'm actually the clinical specialist in the neurology unit. So today I'll be talking about recognizing early stroke symptoms and thrombolysis therapy in acute ischemic stroke, where in other hands, time is brain. So these are the outlines of my talk, where we will talk about what is stroke, the burden of stroke in Malaysia, the stroke risk factors, identifying early stroke symptoms and assessment of thrombolysis therapy, and comprehensive post-stroke care. So this is actually a brief outline for a very large topic. So this is actually to let everyone know what to do when you encounter an acute ischemic stroke. Okay, so the first one, what is stroke and burden of stroke in Malaysia? So in a layman term, stroke means an interruption of blood flow to the brain. Without oxygen-rich blood, brain cells die. And at large, we actually divide strokes into two types, ischemic and hemorrhagic. So our focus today will be on the ischemic stroke, where it occurs when a clot or a mass blocks a blood vessel, cutting off the blood flow to the part of the brain. And we talk about stroke in Malaysia in general. This is actually from our stroke registry in 2016. If you see, the majority of our strokes in Malaysia are actually ischemic stroke, 80% of them. And 17% of them actually has intracerebral hemorrhage, and 2% of them had transient ischemic attack. Transient ischemic attack means that the symptoms resolve by 24 hours. And when we look into the ischemic stroke category, 43% of them were large vessel occlusion, 35% of them were lacunar infarcts, and also 6% of them were cardioembolic with an underlying of atrial fibrillation. Rising on the stroke so much because of that. And if you see, 40% of our populations who actually had a stroke were below 60-year-old, where these are actually the working age group, yeah. And 92 admissions per day throughout in Malaysia, and per annum cost of stroke management is actually a whopping 180 million ringgit, yeah. So that's a lot. And when we talk about how many of them actually have independent living, only 3 out of 10 from the stroke survivors has independent living, and about 32 deaths per day due to stroke. Yeah, so I mean, this burden is something that we need to look into and we need to address them. So what are the risk factors for stroke? In general, these are the myriads of risk factors of stroke. I think Dr. Imran has already talked some of it. Hypertension, diabetes, hyperlipidemia, smoking, ischemic heart disease, atrial fibrillation, family history of stroke. I'm not going to go into the details of this. We'll go to the next one. Okay. So this is where I'm going to talk more on. Yeah. So identifying early stroke symptoms and assessment for thrombolysis therapy. So how do a lay person or a layman know what is a stroke? So that's where we come up with the pre-hospital Cincinnati scoring, where we have a FAST scoring. FAST, what does FAST mean? F-A-S-T. So this is actually something that we should remember. Whenever you see someone having a facial drooping, ask them to smile, the face starts to droop. Or ask them to actually lift up their arms, the arm starts to drift, and their speech is not clear, or the sound of the speech is actually very slurred. And that's the time you need to call 999. So with this scoring, if you have one out of these 3 symptoms that FAS, it predicts 72% of probability of stroke. And when all 3 are present, it predicts about more than 85% probability that the person is actually having a stroke. When we talk more into the FAST itself, FAST normally talks about more of an anterior circulation stroke. We do have a better version of FAST where we call it as B-FAST, where we include balance and eye signs to look at posterior circulation. Yeah, and with this additional of BE, into the fast, we can predict 14% more stroke patients. So how do we evaluate stroke patients for thrombolysis? First, diagnosis matters. Second, exclude bleeding. Third, assess severity. Fourth, identify contraindications. So this is how we look at stroke as a whole. Yeah? It's a race against time. It's a dynamic team effort. It cannot be done by a single person. It starts from the on-screen pre-hospital care, the passerby recognizing a stroke, the MECC who actually accepts the 999 call, and the pre-hospital care. In the hospital, the emergency department plays a very crucial role, triaging, quick assessment, activating the stroke protocol, requesting for urgent imaging. The radiology department facilitated in the urgent imaging, identifying large vessel occlusion, and activating the intervention radiology team when there's actually a large vessel occlusion. And what does our role here, the urology team? We assess the patient for eligibility of thrombolysis, counseling family, liaising with other teams to hasten the door to needle time or door to groin time. So these are the stroke heroes. So how to diagnose a stroke? It's again a clinical diagnosis. The most important question that we need to answer is actually what is the time of onset. If the patient actually in well time is very crucial. Of stroke be mixed that can come or present like a stroke. Things like hypoglycemia, alcohol, cerebral infection, and the list carries on. So how do we then exclude bleeding and assess severity? So to assess clinical assessment of stroke severity, we use the NIHSS scoring, which I'll be talking on later, and CT brain to exclude bleeding and assess severity of stroke based on aspect scoring. So what is NIHSS scoring? It's actually an 11-item score where we can score from 0 to 42, and it's quite simple to do, but need to be a bit of training, because what you need to do is actually look at the response of patient, not really your interpretation of the science. And if it's done well, it can be done by 10 minutes or less. Yeah. And in imaging, we will need a CT brain plane. In the CT brain plane, what we are looking at is actually the aspect scoring. The aspect scoring, what does it tell you is that we look at 10 areas of the brain to look at early ischemic damage or early ischemic signs. So if all the 10 areas are okay, there's no ischemic signs, then we give a score of 10, which is good. If there are areas that's having already signs of ischemic damage, then we'll minus 1. So in other terms, the lesser the number, not good. The good the number is better. Okay. So where are the areas that we look at? It's actually at 2 levels, the basal ganglia level and also the supraganglionic or the corona radiata level. So at the basal ganglia level, you have 7 points, and above that you have 3 points. Okay, and again, we have to go through a myriad of exclusion criteria to make sure these patients are safe for thrombolysis. And when all this is done, so I'll go by this chart with you. I know it's a bit messy. So example, a patient came in with a stroke. Let me just... Okay, so a patient came in with a stroke, confirm a stroke. We find out the time of onset. CT we did, aspect was more than 7. And then we look at the time of onset. If it's less than 4.5 hours, we look at our severity of stroke by looking at the NIHSS scoring 4 to 24, and we look at the exclusion criteria. And if there's no exclusion criteria met, then this patient is eligible for IV, RTPA, or the thrombolysis treatment. Okay, if the NIHSS is more than 25, this is where we need to consult the team, the neurologist, whether would he benefit or not from the stroke, because from the thrombolysis therapy, because with very severe strokes, risk of bleeding and risk of poor outcome is actually higher. And when we do a CT brain plane, we also do a CTA, CT angiogram, to look at any large vessel occlusion. So example, when we did a CTA, there's actually a large vessel occlusion. After the thrombolysis, the patient would be offered a thrombectomy. Okay, if a patient comes with less than 4.5 hours and the NIHSS is actually less than 4, so this is where we call them as minor stroke or mild stroke. Here we can actually treat them with dual antiplatelet as appropriate. Okay, Now, come back if the patient's time of onset is more than 4.5 hours but less than 24 hours with a CTA looking at large vessel occlusion. Here, we need an additional imaging called CT perfusion to look at the ischemic area or the penumbra area. So if there's, we have two areas to look at when we do the CT perfusion, whether it's actually the ischemic or infarcted area. So if the ischemic area is big, then we should save. So example, it's like we should open up the pipe to make sure that the clot is being cleared so that we can save these areas which is dying. So that's where we should offer them thrombectomy. But if it's more than 4.5 hours, they are not for thrombolysis and there's no large vessel occlusion, then single antiplatelet would be appropriate or double depending as the criteria. So what happens if the CT aspect is less than 5 or the hypodensity on the first CT scan was more than 1/3 of the MCA territory? These are also a contraindication for thrombolysis. So what are the choices of thrombolytic agents that we have? It's alteplase and tenecteplase, but so far we do have only alteplase here. And it's actually a recombinant tissue plasminogen activator. It's a bit tedious to prepare, but it takes about 5 minutes to prepare, and the administration goes up to 60 minutes because we give bolus and also infusion in 60 minutes. While tenecteplase, much faster. By a few seconds, you can actually just give a bolus treatment for them. But we don't have tenecteplase here yet, so it's only alteplase which is available here. Okay, and the price for alteplase for 2 vials is about 4,750 here in our UM. Comprehensive post-stroke care. So I talked about thrombolysis and I talked about how we can improve the outcome by giving this thrombolytic treatment. But post-stroke care is actually a major part of the whole continuum of caring for this patient, and it's again not a single person or one-man army show. So it's actually involving so many people: the treating physician, the occupational therapists, physiotherapists, rehabilitation doctors, the speech therapists. So yeah, we do have quite a number of them involved in taking care of this patient, and ideally this patient should be in stroke unit or neurocritical care if they are unwell. So these are my few last slides. We've been recognized as a stroke center by the World Stroke Organization, and for the past Q1 and Q2 this year, we've been awarded platinum status. So congratulations to all our stroke heroes. With that, I thank you.
Thank you, Dr. Prasana. Here, I'd like to emphasize the Platinum Award is actually a teamwork involving neurologists, rehab specialists, ED radiologists, and also our allied health as well. Okay. For the sake of time, we'll choose one question to answer. Maybe Prasana can choose one question to answer.
So I think I got two here from Prof. One. So it seems that the root thrombolysis is quite subjective and depends on many interpretations from different users within range of NHS scoring, aspect interpretation of CT brain, and contraindication for thrombolysis. Would that contribute to different outcomes? So I mean, in terms of the subjectiveness of measuring NHS scoring, I think with proper training, all of us should get the same scoring, no matter how many people have done the test to that patient. Okay, aspect interpretation also, I think that's where we do have a discussion between the radiologist and also us in the same time. Contraindication, this is actually to protect the patients. Yes, I know thrombolysis is actually helpful, but these contraindications are just to make sure that we don't cause more harm for the patient, because at the end of the day, do no harm is the first thing ever in our practice. Okay, so Dr. Yu said it's an emergency and you're fighting against time. How does a patient raise 4K involve? What do you do for poor patients? Okay, so we do actually have our tabung stroke here. We do offer assistance for patients who are in the poorer background. So also, it's not a contraindication, or when patient should still get their treatment of care, although they are unable to afford it. So there's always a leeway.
Yes, regarding tapeworm stroke, we actually have a tapeworm stroke to help the thrombolysis and thrombectomy patients, those with who are unable to afford the LT place and also thrombectomy. These patients will be assessed by social worker, but in emergency, we will actually, I mean, it's actually being not being able to afford LT place is not like what Prasana said, it's not a contraindication to LT place lah. We can still go ahead, and then the next day social worker will assess the patient and determines the affordability of the patient. Okay. Thank you very much for all the questions that we posted. We apologize that we could not answer all that. I've seen some input by Prof. Tunku Sarah as well. Thanks for your congrats. Thank you.